Hi there. So when I arrived, they said, gee, do you mind all the rain here in Seattle? And as you heard, I came from Cleveland. So for us, it's gray and icy. And in contrast, gray rain is beautiful. I just love gray rain. So it's a marked improvement. And thank you for your kind attention and for adding me in kind of late into the course. And let's see, slide forward. Okay. I think it's pretty easy to make the ear very, very confusing. And I think it's harder to give you guys a couple of good thoughts that you can take home that might make a real difference in your practice with seeing vestibular patients. The goal is to try to make it as time efficient and effective in terms of coming up with an accurate diagnosis that can help the patient. And so that's what Doug asked me to talk about. We're going to talk a lot about vestibular evoked myogenic potential, which I do on just about every patient who comes in, because as John Carey says, you know, it's the great imitator. Canal dehiscence presents lots of different ways, as well as a very directed bedside evaluation. As you know, there are a lot of dizzy patients out there. When I put up a sign that says, you know, dizziness here, the challenge becomes how to handle the volume of folks who have this complaint. It's believed to be the most common complaint that takes adults to physicians. Most recently, the count was 8 million US visits. And if you just ask the average adult, have you had dizziness more than 2 weeks? 16% of the population will say yes. So it's a really, really large number of folks. They went door to door with the National Health and Nutrition Survey in 2001 to 2004. And this study was published with the aid of the Hopkins folks, and found that when you ask adults to stand on a compliant surface and close their eyes, so they're depending on their vestibular system, 35% of people could not reliably do that. So there's a lot more vestibular pathology out there leading to fall risk than I think we really appreciate. If you have the time to take a careful history, about 70% of the time the diagnosis will become pretty obvious. The issue is, of course, that patients want to use the word dizzy, because they don't have very many other words. Equilibrium is an unconscious sensation, and I didn't wake up this morning and say, oh, my equilibrium feels today. You know, you're not aware of it. So when it goes away, there's not a lot of words we can reach for. So the patient uses dizzy for fainting, for staggering, for not remembering where you're going, for lightheadedness, for vertigo, for everything. So one of the keys is to help the patient not use the word dizzy, but to try and narrow them down. You want to know a lot about the first episode, what exactly they were doing. The patient will typically say, I've been dizzy for 2 weeks. Doesn't give you any info. You want to know, did they just lay down, roll over when it started? Tell me about what you were doing when it first started, and you'll get a gold mine. You know, I laid back, I was getting my hair done at the hairdresser, BPPV. In my world, it's BPPV unless proven otherwise. Because even after they've been through all kinds of visits and doctors and MRIs, they probably have BPV. Less than 30% of ENTs do Dix-Hallpikes to check for positional vertigo. Slightly more neurologists and hardly any primary care providers. So I do a lot of talks around for primary care. Please just do this during your routine office visit, and you'll find a lot of patients. So you want to ask about it. I certainly always tell people, try and look at the eardrum. Make sure you're not dealing with anything nasty and destructive. There's a lot of press right now about HINTS testing. So this is head impulse nystagmus test of skew, and it came from Newman Toker at Hopkins, who's a neurologist, who basically says this is a great way to identify patients who are having a stroke when they present to the emergency room with isolated dizziness and vertigo, because MRIs are much better than CTs for this kind of stuff, and they don't show abnormalities acutely. It shows very acute abnormalities. So there's a lot of interest in it. Head impulse testing. Oops, there we go. No special equipment needed. You ask the patient to look at your nose. You bring their head over quickly. I just do horizontal canal because vertical messes up my neck. And if they can keep looking at your nose, they pass. If they can't, you bring them around and their eye goes right past you and they have to jump back. So I'm rotating right I went right by you and I jumped back, my right ear is weak. So that's head impulse testing. Do it right there, no special equipment needed, no Fresnel lenses, nothing. And it confirms a unilateral weakness. So let's say they have a left beat spontaneous nystagmus. You wonder if their right ear just dropped function. They have an abnormal head thrust to the right. And that looks pretty consistent. You ask them to fixate and their nystagmus decreases. Now, to eliminate fixation, there are a number of kind of interesting tools coming out for this. We've got portable Fresnel lenses, which are the little, oopsie, I don't really need this, okay. We've got portable Fresnels, which are the little guys with batteries, but they're still kind of heavy. There's something called M glasses, which Joel Goebel and I have tried. They're nice, they're really light. They clip on your nose like the old-fashioned spectacles. And they can stay on with the head shake. And they're engineered very cleverly, so they're thin, but they really magnify the eyes and eliminate fixation. And they're going to hopefully be marketed in the States soon. And it's not like getting a whole video system. It's just, little glasses you can pop out of your pocket. So what are you looking for? If you could play my video, please. I think you have to turn it on back there. Thanks. So what's nystagmus? It's just this one, you're looking at the patient. The right side is over there, left side's toward me. This nystagmus, we name it by the fast phase. This is a right beat. So if a patient comes in with that and they look to the right, should be more. They fixate, it should be less. Now you've got head impulse, nystagmus, and it's all looking very peripheral. The last part you add is test of skew. And if you remember that, it's confrontational. You block one eye, and they're looking at you, and you uncover, and this eye should still be on the same level. If you do this and you uncover and this eye moves up or moves down to get to target, they have a skew. So it's just an uncover test. It takes 10 seconds. Head, impulse, nystagmus, test of skew. Extremely sensitive in picking up patients who are central versus peripheral origin for acute vertigo. Now, that's new, so that's all the new stuff coming out. You'll be hearing a lot about HINTS testing. What I used to tell my residents, the other thing is for an acute peripheral lesion, is the patient won't want to walk. They're really dizzy and they're saying, I'm so dizzy, nauseous, hanging on to their friend. But their legs are working. They can actually move their legs. They're able to walk. They don't want to, but they can. With a cerebellar infarct, which is your common central reason to have an acute isolated vertigo, your legs won't work. Motorically, you try and step and people just crash to the side. So the message for the residents is if they can't walk, they shouldn't walk out of the emergency room. So postural control is another part of the evaluation, trying to determine, is this something to be really worried about or does this look more peripheral? So postural instability, and that goes back to Balo's group, who first published this in the New England Journal of Medicine in 1998. Very interesting changes in the use of head CTs. Of course, most of you know if your patient went to the emergency room and presented with vertigo, they got a head CT. And with my patients, they go back to the emergency room. They get another head CT. One patient had 5 head CTs in a week because every time they go, they get another head CT. Head CTs do not image the posterior fossa well, and they're good for picking up bleeding, but not for picking up other structural processes we care about. Acoustic neuromas, other kinds of cerebellar tumors. So the American Academy of Emergency Medicine arguing against the use of routine head CT in the emergency evaluation of dizzy patients. So of course, be aware of other signs of stroke and the risk factors. And I see my time is charging away, so I'm going to move along. We do give oral prednisone for acute vestibular syndrome. It might help. Randomized study from Strupp in the New England Journal of Medicine 2004 did show some benefit. So I tell folks, if you see patients, they look acute, send them on over or have a PT, look at them with goggles, and we'll get them some steroids quickly. After 3 days, vestibular suppressants don't do much to help. They actually may inhibit recovery and adaptation and compensation. So you can certainly use them for patient comfort for a bit, but then don't continue. So a lot of people have BPPV. You guys know all about it. There are some national guidelines that came out from our academy and neurology that are currently being revised and updated. And I'm on the equilibrium committee, so I'm part of this whole process. The recommendations are perform Dix-Hallpike maneuver. Your ENT exam chair can usually go flat enough to achieve that. Don't do imaging. Send to PT or try repositioning yourself. Can't hurt people. And only if symptoms persist or are unexplained do you want to do additional testing. So if it's just BPV and you just see it, try and treat it, send them to PT, and we don't do the, quote, blue plate special on those folks because it's pretty obvious what they have. Maybe a hearing test because it can be BPPV plus. Some patients with acoustics get more frequent BPV. So I like to do a hearing test, but that's it. So what we're looking for, if you could click play, please, it usually is posterior canal, and there's a otoconal debris in the posterior canal, moves with gravity. Pulls that endolymph away from the ampulla, stimulates the posterior canal, and you get the characteristic torsion. It's really common, really, really common. John Ogilvie did an interesting study where he went to Pittsburgh and said to patients coming in to get their asthma checked, hey, can we just do a Dix-Hallpike? These were not patients complaining of dizziness. 9% of them were positive for BPV. So these are folks who figure, oh, I just, get real dizzy when I get up because I'm old. So I'm just careful how I move, and they tell you I sit for a while. But what happens is, something goes crash, or it's the holidays, and they go up to reach for the turkey platter up on the chair, on the high thing, and all of a sudden it hits them, and it increases your fall risk by 8 to 13 times. So well worth it to educate our primary care colleagues to look for it. And this was a little article I wrote that's gotten publicized a bit about how to do it for primary care without any equipment. You have them look at you, you lay them back, you don't overextend the neck, you don't need to, and a little video. This goggles really help because you don't have to kind of climb over the patient. It's like doing endoscopic sinus surgery. It's so nice to do it when you have your camera and your screen and you don't have to worry about it. So I have my little goggle set up there that I use. Okay, and you see the characteristic upbeat torsional nystagmus with a little delay and kind of has a rhythm to it. Boom, 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 boom. Boom, 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 boom. You can almost imagine the particle rolling, has a swing to it. Other vestibular disorders can cause weird nystagmus, but they don't have that pattern. That's BPV. You've got them down already, just roll them toward the good side and sit them up and you're done. Takes, what do you think, 3 minutes? I do it fast. I do it like this. It has a CPT code that reimburses for physicians, 95992. This is my nurse allowing me to demo, and this is how fast I do it. And then I'll take them back at the end to check. I'm going to move quickly, and what we're doing is repositioning out of that posterior canal. This is a right posterior BPV. And as you do the maneuver, the particle's going to fall back into the utricle. And I tell them to sleep on the good side for one night after, but it's not really evidence-based. This is the other side, this is the left, and I just included this because the eye movement can be a little disconjugate. The uppermost eye is usually more vertical, the lowermost is more torsional. So if you just have one camera, or you're just looking, focus on the undermost eye and you'll see stuff better. And there's the little guys, little otoconia. They are the size of a red blood cell, 6 microns. They're constantly growing and flaking off, and it's just bad luck when they fall into the semicircular canals. You can also have BPV of the other canals. It looks different. I'm not going to go into it in detail today. I can certainly send you information about that. I see a lot of other canal stuff because I get, the ones that haven't gotten better with simple treatment. I'll move along. Recurrence is common. There's a really good movie on the American Academy of Neurology website by Radke, How to Do Your Own Canalith Repositioning. And this is catching on. Put the pillows behind your shoulders, how to identify the affected side. I also did a lot with Cleveland Clinic. There's all the videos there, animations for patients, how to identify which side it is, how to do your own repositioning with pictures and a little blah, blah, blah. I haven't set that up here yet. But probably more of interest to you guys is there is also not so benign positional vertigo. It's not all BPPV. So if it persists and it doesn't respond to repositioning, your little feelers should be up because it can be some other things. Now, I trained with Hal Shuknick at the Eye and Ear, so we're all indoctrinated on Saturday morning at 6 a.m. in our white coats about cupulolithiasis, which doesn't appear to really explain that much BPPV since we discovered canalithiasis. But I've come across superior canal dehiscence causing what looks like BPPV. You lay them down, it doesn't quite have the same rhythm, but that CSF is washing into the superior canal, and you get a little torsion there. So again, it's the great masquerader, the canal dehiscence. So we do VEMP on our folks who have persistent symptoms, looking for that. If it's a little scattered nystagmus, I usually don't worry about it, but if it's a constant unidirectional, more than 6 degrees nystagmus, I've seen that with cerebellar tumors in adults, in kids, stroke, multiple sclerosis, all kinds of structural pathology, acoustics. So look further into folks who have nystagmus that's not BPPV. If they lay down and it beats away from gravity, 50% of those people tend to have other associated vestibular test abnormalities, sometimes cerebellar degeneration. I'm going to skip that one. The Academy is currently working with the Baronnet Society to change the definition of Meniere's disease a little bit. And so we're requiring the presence of hearing loss. That's not new, that's since the 95 guidelines. But we're also shortening the duration of the episode down to 12 hours. So it has to be greater than 20 minutes, less than 12 hours to qualify as Meniere's. Reason being that these migraine things might not have hearing loss, and they tend to go on for a longer period. You all know about high drops. We did an interesting study where we injected intratympanic steroids and found that about 39 out of our 41 patients that we published, substantial improvement in symptoms, not needing to go on to further surgery or gent after intratympanic steroids. So they're pretty easy to do and relatively low on harming the patient, and they might just buy you a little time, because we all know Meniere's gets better a lot on its own anyway. That's the challenge in proving anything works. They're probably going to get better on their own if you just give them some time. So about 80% spontaneous improvement in Meniere's, but it does help. Canal dehiscence, again, pressure or sound-induced eye movements, and here is your temporal bone showing a big old dehiscence. Interestingly, when they get this big, sometimes they don't cause symptoms, and I'll tell patients, if you're not that bothered, just wait, and let's see how it goes. We can analyze the type of stimulus you put in, where the endolymph goes, what the eye movement is like. It's kind of fun to do that. We put loud tones in the ear, and you can see the torsional nystagmus in the plane of the canal. This is a characteristic audiogram. Remind your audiologists to do bone curves and take them up high, over the air. Usually these folks have that interesting conductive gap where their bone curve is higher than normal. So an audiologist could see that air curve and say, hey, that's normal. But only when they do the bone do they see that it's supranormal. And that's a nice way to pick up dehiscences. VEMP is very good. We're moving now from cervical VEMP probably to ocular VEMP, because the ocular is a little faster. You put electrodes infraorbitally, and it's just faster to do. The patient looks up, the sound, and it's really clean, and it's frankly faster than the cervical, where you have to bend the neck and keep it, constricted and try to get the inhibition. The ocular VEMP is just a little muscle activity, easier to pick up, cleaner, faster, easier to do in the office. Patients don't have to lie down. So we're moving more to ocular VEMP. We also see interesting, so the VEMP picks up any third window. It's fun. We have found posterior canal dehiscences causing positional vertigo. We also have found a number of enlarged vestibular aqueducts, and I think this is fascinating. These are EVAs of people coming in complaining of positional, usually my clinic, positional vertigo, who don't have a hearing loss. Adults. The VEMP is abnormal. We get the CT, and they've got EVAs, and some of them are pretty substantial EVAs. enlarged vestibular aqueducts. They don't have hearing loss. So I wonder if our understanding of EVA wasn't based on the fact that the kids who have, progressive hearing loss are identified because they have hearing loss, and then they get the CT, and then we call it an EVA. But now we've got a different tool. Now we can get VEMPs. We pick up a third window. They have an EVA, and they've got atypical nystagmus. So we're going at it a different routine, and I just published this series and presented it at Baronet of the substantial number of folks coming in with normal hearing, EVAs, and complaints of dizziness. So a CT temporal bone and a VEMP or a VEMP, very good to do if you have a weird persistent complaint of dizziness. Migraine. About 25% of people with migraine will have episodes of otherwise unexplained vertigo. Very common. We hear the story of the world tilting or the tunnel vision, or just sick, horrible, green, vomiting, weirdness. If you calculate the number of people in America who have migraine, 35% of women, and 25% of them get unexplained dizziness, and you average it all out, you're 10 times more likely to come to the dizzy doctor's office with migraine than you are with Meniere's. Just the number of people with migraine is so large. So it certainly should be on our, list of things to be concerned about. Headache does not have to occur at the same time, but they have to have a history of American Headache Society criteria meeting headaches at some point in their lives. Usually it's during adolescence. Beta criteria were just released by the International Classification of Headache Disorder. So now the neurologists can't say, oh, migraine doesn't cause dizziness. You can say, yes, it does. So, and this just came out like a year and a half ago. So 5 attacks have to have a history of migraine, either with or without aura. Vestibular symptoms of moderate or severe intensity, 5 minutes to 72 hours. At least 50% associated with either an aura or photophobia and phonophobia or headache, but not always headache, and not better accounted for. I don't make this diagnosis unless I've excluded my world. I don't want them to have an acoustic or an inner ear problem that I'm missing. So I do the whole workup. I don't find a darn thing. They got a history of migraine, and I say, hey, we should have you try a migraine preventative medication and see if it helps. 70% of patients that I send do get better with migraine preventative medications, and it can be as simple as magnesium oxide, 400 milligrams a day, works great. B vitamins, get enough sleep, don't miss meals. I mean, it doesn't have to be fancy migraine headache center stuff. Chronic dizziness. So at the clinic, at the Cleveland Clinic, they answer the phone and say, would you like an appointment today? And so there's a lot of dizzy patients who want to come right in. We suggest they start with their primary care. It's called chronic dizziness if it's more than 2 weeks. And then we help the primary care folks try and figure out where they should go next. And key to that is starting with a Dix-Hallpike, because it's likely to be benign positional vertigo. Primary care folks can do Dix-Hallpikes, and if they see it, send to vestibular physical therapy. So they're rooting right around. Every dizzy patient does not need to see neurology or ENT. Although, if they have a hearing loss, include ENT in that loop. And if they have other neurologic symptoms, headache, ataxia, motor weakness, anything else neurologic, they should see a neurologist. So we kind of catch the worrisome symptoms, but send patients from primary care to our friends in vestibular PT. So that's the start, is the vestibular physical therapy referral. We build lots and lots of vestibular physical therapists doing this system. We had 20 in Cleveland, and I'm in the process of building that here. Refer to ENT if there's hearing loss. Those are the patients we want to see. Refer to neurology or sometimes cardiology if there's syncope. If you're going to be a primary care and you want to get imaging, please don't get a head CT. It doesn't really help much. So we talk to our primary care colleagues when you're ordering an MRI, make sure it has contrast. After patients have vestibular problems, you can compensate. So if one ear goes, we can train the other ear. If 2 ears go, hypofunction bilateral, you can actually recruit the neck proprioceptors to stabilize vision with head movement. So there's all kinds of treatments for various vestibular disorders. Meniere's not so much, but once it's stabilized, they might have a unilateral weakness, and then we can treat that with physical therapy. Vestibular suppressant use really probably long-term does more harm than it does good, because patients feel great when they take an Ativan or a Valium. I mean, great. These are dizzy patients, and it makes it all go away. But the problem is you habituate so quickly. Within 3 days, you don't get a therapeutic effect, and now you're tolerant, and you discontinue the medication, and you have withdrawal, which is dizziness, which makes you think you're back where you started, so you take more. So people really do get addicted, and at least in Ohio, it was a leading cause of death, was overdose from benzodiazepines. So I discourage use, especially patients who are over 65. It's been shown by the American Academy of Geriatrics to lead to accelerated dementia, falls, motor vehicle accidents, memory difficulties. They metabolize it slower, and they just don't handle it very well. So I tend to avoid benzos after that little 3-day window. Here in Seattle, we have the New Balance Center, which I invite anybody who wants to come see. At the end of the day, I can take you over. We have some nifty new vestibular assessment equipment. There's a rotary chair with completely open. You don't need the surround anymore because the video systems are so good. So you sit in this little chair, and it kind of moves, and you got a big screen, and little lights go on it, and it's like playing a video game. You know, the kids would probably buy a ticket to ride in it. It's really fun. So we don't need the old surround. We don't make people as sick anymore with vestibular evaluation like we used to. And we work closely with our colleagues in audiology and in physical therapy as well. So we are putting up patient education materials. They're in process. It's coming probably next week about benign positional vertigo, Meniere's, vestibular neuritis, canal dehiscence, vestibular rehab, and just a general what is dizziness information. And I thank you for your kind attention. And I think